I'm Dr. Kenneth Silver. I'm a pediatric neurologist. I'm here at the ATP1A3 meeting. It's just started, but it's already very excited with many different scientific findings to try to help explain these groups of paroxysmal diseases. And what do I mean by paroxysmal diseases? These are disorders which come and go with different kinds of neurological symptoms. And over the years, we found that many different paroxysmal disorders now are responsible secondary to ATP1A3 mutations. My interest has been alternating hemiplegia of childhood. I saw my first patient probably more than 30 years ago. And since then, I've been very involved in treatment and research of alternating hemiplegia of childhood, probably seen more than a couple of hundred patients and treated many of them, and with interest in flunarizine being one of the drugs used to treat alternating hemiplegia of childhood. And we're still looking hard for some other drugs which might be more effective. What's most dramatic in the last year or two is that the syndrome is expanding in our identification of different subtypes. So now we see with ATP1A3 mutations, it causes other syndromes which are like alternating hemiplegia of childhood, but are very much different in many respects, but yet it's the same gene. And what we found is certainly different sites, these mutations occur and produce different manifestations of the disease. One of the manifestations is dystonia, which is strong co-contraction of opposite groups of muscles. And this at times could be very painful. And I see one of our parents had asked the questions, are CK levels affected in AHC? So when you have severe dystonia, you're constantly contracting your muscles. You might even stretch out or tear some of these muscle fibers. And we know patients who have very aggravated dystonia, it does cause some muscle tissue damage and can increase the CK. But usually for a hemiplegia or just in between attacks, the CK should not be affected. Another question is, what percentage of kids show decreased physical abilities as they get older, and why? Most children, as they become adults with alternating hemiplegia of childhood, they remain relatively stable. What is concerning is a smaller group of patients where they have a bad attack, meaning they have a severe dystonia, where they have a prolonged episode of hemiplegia. It can take them longer to recover. And in some children, they don't recover back to their baseline. So they remain at a lower level of impairment. And sometimes they can have seizures and prolonged seizures, such as status epilepticus. And some of these children don't recover back to their baseline after these very bad attacks. So another question is, a vagal nerve stimulator worth a shot? This is something else I've been interested in over the years. There are other patients with alternating hemiplegia of childhood who had vagal nerve stimulators inserted to also treat their epilepsy. Some of them report benefit, others do not note any benefit in their hemiplegic attacks. I think that this is not something I could recommend as treatment because it's invasive. There are risks. I think one probably should study it methodically, that a controlled study of these patients on VNS with without VNS for alternating hemiplegia to really define, is this something worth using in patients who only have alternating hemiplegia and not seizures?